I'll review today a brief critique of a study that I just read that uses MDT exercises and kind of give my thoughts on where I think this study goes right and where I think this study falls a bit short. So the study was entitled "The Addition of McKenzie Exercises to a Multimodal Physical Therapy Approach for Cervical Radiculopathy, a Case Report," and it was published open access in Cureus in 2022. Cureus seems like it's a newish online database that has open access publications. I approve of the open access, but sometimes I think you got to weed through to figure out what you're getting in terms of study legitimacy on these websites. So as far as I can tell, when I looked up the two authors, they do not have credentialing in using MDT or the McKenzie method, also known as mechanical diagnosis and therapy. Maybe they do, but I did not find those letters after their names. In order to say that you use MDT, you need to be either certified or diplomaed. I am diplomaed, which is the highest level of training in MDT. There are about 550 of us around the world, and there are many more people who are certified or credentialed, but it's a postgraduate thing since it's not readily taught in most programs that have to do with medicine. So I take their understanding of MDT with a grain of salt per the study, but also because I don't see that they have the credentialing, that they've learned the methodology. So that comes across a little bit to me in the title, because there are no such thing as McKenzie exercises. There's a methodology, there's repeated movement testing that he invented, there's the treatment for joint derangements that he invented, but outside of that, he didn't invent neck retraction or knee flexion, for example. Rob McKenzie's contribution was primarily repeated movement testing. Use it to be confident in your diagnosis. And when you use repeated movement testing, you'll find that 70 to 80% of people who present with pain that are orthopedic in nature can have their problem fixed with repeatedly moving into the direction of preference for that joint. So they note that the impetus for the study is that there is not evidence in the guidelines for treating neck pain that has to do with implementing MDT. And that's true. There is sufficient literature to support using MDT when it comes to low back pain, and the low back pain guidelines reflect that, but it's not so much supported in the clinical guidelines for neck pain, which I think is a problem. We need more research to kind of garner that support. And when I think about guidelines, I read them, I understand them, and I do what's best for my patients in my clinic. And that is supported by the evidence that I see when I work with patients one-on-one. So again, going back to McKenzie exercises, that's a bit of a misnomer. And they also use the phrasing McKenzie centralization exercises. And that's also, it's not a term that I use or that we use. We look for centralization. If we see centralization of a patient's symptoms moving from distal to the spine, that indicates a good prognosis, an excellent prognosis, in fact. But the absence of centralization in and of itself is not a negative at all. So when they talk about a multimodal physical therapy approach, they're basically referencing the standard. And I think the standard of care does fall short. I don't think we're really addressing patients' disorders and reversing them to a large degree when it comes to orthopedic care in this country. And so I think that's reflected in this study, because they're saying, look, if we take kind of the standard and we implement a McKenzie exercise, what happens to the patient's outcomes? So the multimodal therapy was thoracic manipulation, which is manual, rib mobilizations, which is manual, I'm assuming, manual traction, nerve mobilization, postural exercises, and scap retraction. And I think they even did the manipulation on day one. So they are using quite a bit of manual therapy, and they're using different things. And to me, it's very rare when I'm throwing 7 or 8 different things at a patient. If I can find the root cause diagnosis, I find in most cases that is one diagnosis and one treatment. Just like if you have a scrape on your knee and it turns out there's a fungal infection, you're getting the one antifungal that is matched to that particular infection. So that's kind of where they started, and then they added cervical retraction primarily, but retraction with overpressure from the patient. They also mentioned that MDT is an approach of PT that can be used for the treatment of spinal pain. And it's not an approach of PT. It's an approach to orthopedic complaints or non-orthopedic complaints. You can use repeated movement testing with, headaches or sinus issues. You can use it to figure out if the problem is orthopedic in nature. So it's not just for PTs, it's for any clinician who wants to spend the time and energy and money and bandwidth learning it. It's not specifically for physical therapy. I would love it if orthopedic surgeons were using repeated movement testing for their diagnostics. That's not going to happen in the near future when visits are 10 minutes and not repeated when the patient comes back with the result of the repeated movement test, and then it's further changed if necessary. But repeated movement testing in and of itself is diagnostic. So they say the treatment of spinal pain, yes, but MDT can also be employed. Repeated movement testing can also be employed for non-spinal complaints. So going back to the patient's care, they started by taking baselines, which I really love, and they also delineated the baselines at the end of care. But they looked at 6 ranges of motion for the neck, but they did not include retraction or protrusion, which I think are important ranges of motion to include. It's hard to quantify how much retraction or protrusion a patient has, but to me it's quite important, especially with radiculopathy, which is radiating nerve pain down into the hand in this case for this patient. You want to know if protrusion and retraction are full range of motion and if they're painful. So they also take baselines of nerve tension and strength and get a kind of a sensory understanding of where there's a disturbance in the dermatomes, and they found one in the C6, C7 dermatome in the distal upper extremity. So they include, among this multimodal approach, cervical retraction, and then they add cervical retraction with overpressure. They show a picture of it seated, so I'm assuming that it's seated. However, they also say that in the office they use manual cervical retraction with cervical extension. They do not mention if it's seated or supine, but I'm assuming it's supine because in seated I don't apply manual overpressure to extension of the cervical spine. But that lack of clarity is problematic because when we use repeated movement testing or repeated movements as treatments, we need to be very specific about the load. Seated retraction is different than prone retraction, which is different than supine retraction. And does that mean that every single person has to be super specific with what they need? No, there are people who might respond to retraction in any load you put them in, but there are some patients for whom retraction and seated will not fix that joint arrangement, but retraction and supine will. So that specificity is a necessary component when you're describing the repeated movement. So that was one of the shortcomings that I found, is I don't really understand what they're doing. And also, they mentioned that they did that manual cervical retraction with cervical extension in the office, which abolished the arm symptoms, yet the patient went home with simply retraction. So that doesn't really follow the essence of MDT, which is if something's abolishing distal symptoms in the clinic, that is a green light, and that is the indication that that exercise should be the home program. Also, if it's in the C6, C7 dermatome and there's grip weakness and arm weakness and it's all the way down the upper extremity, I'm assuming, or I know, that it's going to be in the large majority of cases a problem with the lower cervical, upper thoracic. So retraction, in my experience, is not typically enough to really fix these problems. You need to get end range of the lower cervical spine, which in the sagittal plane would include extension. So they do some extension, but not very much. I'm also unclear about how much the HEP is. What is the dosage? So when I employ repeated movement testing at home, the dosage is almost always 5 to 10 repetitions every few hours. And it changes based on irritability, etc. But that's a really good starting point if you don't know where to start. Now, I don't know if that patient did it once a day, or the retractions twice a day, or 3 or 4. Even if it's 4 times a day, that doesn't quite get to the dosage that I would require to call that test valid. if the patient comes back worse, better, or the same, I don't know if the exercise played a role. My minimum to really hone in and figure out if that exercise is contributing to the patient's change or not changing is at least 6 times per day. And I try to get patients to do it 8 times a day or more. So the home exercise program is a bit unclear there. It's also unclear as to what other things the patient might be doing at home. And again, I want to do just one thing to figure out if there's one movement, one directional preference that fixes the disorder, which I do find in most cases. And if I confound that with other variables, other exercises, that's not an ideal situation when it comes to diagnostic testing. So yes, I mentioned this before, they're not going through extension. So going back to what I just said, they write in their limitations of the study that it does not determine cause and effect, which I would argue is a really important limitation, because if we did just one movement, we could more confidently say the cause was a problem in the lower cervical spine, creating nerve radiculopathy or symptoms into the upper extremity, and it was resolved with just retraction or resolved with moving the joint to retraction extension. Then we can determine a cause and effect. But if we do 7 different things and different manual therapy in the office, we cannot determine cause and effect. We don't know what fixed that patient. And I think it's important to know, because when there's a strong likelihood the problem will return at some point in this patient's life. And then if it does, that person, if we know the cause and effect, can get on that one exercise again and likely clear the problem without seeking a clinician's help. So I want to, in the most times possible, I want a specific cause and effect with one intervention, not a multimodal intervention, because then how do clinicians learn what is most effective? Because maybe we were spending all this time on doing 7 things when we could have gotten the patient better in half the time if we just did the one thing that was really important more often. Again, I mentioned how they take baselines, which I think is great, because so many studies, you read them, you don't see what signs change. You learn about symptom changes, meaning pain changes, especially with using the pain scale, and you learn about functional changes, usually regarding functional scales, but we kind of miss out a lot on the baselines, which I think are really key to understanding if an orthopedic disorder has been reversed or not. So again, they looked at 6 ranges of motion for the cervical spine. 3 of them stay the same, 1 improved and 2 decreased. So that's a little bit confusing. Not super significantly decreased, but I'm not used to seeing range of motion decrease 2 out of 6 when the patient is being discharged. But the nerve tension was better on the unaffected side, but stayed. Positive nerve tension on the affected side. Grip strength was better. I think it was shoulder flexion or another muscle group of the upper extremity was better. And dermatome sensation was improved over 90%. So in general, the patient's at least 90% better or so, but I would love to see all of those signs better, all of them reversed to 0. So excellent in terms of 4 visits over 5 weeks. That is above the standard of care. Can we attribute it to the cervical retraction? No, because we don't really know what was going on when so many different interventions were happening at the same time, and we don't know if the home exercise program even included that on a regular basis. But the patient did have marked improvement, and they talk a lot about patient empowerment, which is wonderful. And I think that should be a goal of clinicians, is to teach patients they're in charge of their own health and that they can usually fix their own issues if they're taught how. Yet, in contrast to espousing patient empowerment, there's a bit of manual therapy and more than one different type. And I think that either consciously or subconsciously teaches patients that they need to have something done to them, that they don't have that control. So I would love it if we kind of encouraged patient empowerment and decreased the dependence on manual therapy or other kind of passive therapies in the office. And along the same lines, the authors talk a lot about centralization in this paper, but the patient doesn't demonstrate centralization. Up until discharge in week 5, the patient was still having intermittent arm pain. So it wasn't a centralizer. So I don't know why the patient or why the authors use that word so often. Maybe the patient would centralize if they were doing cervical retraction extension with patient overpressure 8 times a day at home. I don't know, because I don't know what they used at home. And again, you also confound it with all the different things in the office. So overall, it was a decent study, but the takeaway is kind of that people who don't know MDT, they might look at studies that employ part of MDT, but they're missing the essence of it, right? The essence of MDT is you can do all your normal orthopedic stuff that you learned, but you can do repeated movement testing to figure out if, instead of all that different stuff that you learned, pulling on bands, deep neck flexor strengthening, manual traction, postural exercises, rib mobilizations, you can do repeated movement testing to figure out if this patient is one of the 70 to 80% who just needs 1, maybe 2 exercises. It could take a visit or 2 or 3 or 4 to figure out that one exercise. But let's figure out if that patient has one exercise that will fix the problem and measure changes in baselines based on that cause and effect of just that one movement. So I like that there's some interest in using MDT, but I would argue it would have been great if they had someone like me or a diplomat proofread or edit the study to say, this makes sense, this doesn't make sense, why would you do this? MDT, people who use MDT well, who have learned it and employed it for years, would never do that. So we can say this is just adding cervical retraction, but lots of people use cervical retraction, right? So then that wouldn't be really using what MDT is. So when you read studies like this, be a little bit curious about how people are going about using the term MDT and centralization, because if you're not really familiar with how repeated movement testing works and how it can be parlayed into finding the one repeated movement that the patient needs, then this study can misrepresent how clinicians like me, use MDT.